Okay, hello everyone. I'm Abadat, and I'll be doing this presentation on portfolio presentation, CBD, KEX, role of ES plus SS, audit, and QIP. Okay, so portfolio is just a way of making what you do count. It demonstrates your clinical learning and professional development as you're as you're carrying out the procedures, seeing the patients, taking history, doing examinations. We can make it count by recording all of these sessions in the portfolio. And then the portfolio has different uses. If you're in training, it helps you progress to the next stage. If you're not in training, you could use it to gather your alternate competencies to get sign off and apply for a higher level like ST3, or some people would use it for their Caesar pathway to become specialists in their various fields. So the focus area will be on CBDs, that's case-based discussions, your KEX, clinical evaluation exercise. The ES is the educational supervisor. The CS is the clinical supervisor, and then there's the clinical audit and quality improvement program. So the CBDs, I'd put a picture of like my portfolio is the RCOG one, and then how it looks whenever you log in, how there's the CBDs. If you click on the green button, you can request something if it is case-based discussion or a mini KEX or not, or OSAT, like if you've done something, let's say, for example, you've done a section and then you could request assessment for it. The formative would be like you're just learning, it's the beginning. You could be assisting and be sending OSAT formative. And then there's the summative. The summative is the one that is the competence, or there's working towards competence, and there's competence. Okay. Before you're deemed competent, you have to have three signatures: that's summative, that is competence, not working towards competence. And then so people like to see the growth from the formative to the summative and all. But then if you need to, anyone that is alternate to competencies or what, whenever they will be able to say that you're competent for something, then you must have like three summative signatures that's competent. And then there's the TOIs, that's the team observations that's done at the end of like 6 months in a posting. Like the trainings would rotate every 6 months. And then you just try to get some feedback, like what do people think of you while you were with them? And that's TOI. So that's that one. There's another part about reflections on it could be, and then there's the part that is to log procedures. Let's say you are now competent to do your cesarean sections and you're beginning to log the procedures as to what you're doing in your Caesar pathway or something. There's the other one. And there's the part to reflect about whatever it is. It could be a case that you've been involved with. It could be a complaint. It could be a detex. It could be anything you can reflect. It could be a conference that you attended and then you can reflect on it. There's that as well. So if we go to the case-based discussion now, case-based discussion, basically like you have seen someone in the emergency medical ward, maternal assessment unit, wherever you have, and then you've taken a good history, you've arrived at a diagnosis, then you can discuss with somebody. And then it starts with what you have done with the patient, how you've taken the history, how you've arrived at your diagnosis, how you've examined the patients, how you're going to be discussing the differentials, and then how you're managing the patient. So this is like an oral assessment. The person doesn't have to be there when you're seeing the patient. So the person doesn't have to be there when you're seeing the patient. You've just come to discuss with them, and then they fill in the gaps. There's a place for them to do their comments, like the assessor's comments on how well you've done the presentation. There's something about CPD. I've also shared how the portfolio looks like the areas that you need to fill in, and then you send the request, you send it to the person's email address or the person's address on the society, like if it's RCOG, you send it. Once you put their name in and they are registered on the portfolio, it comes out immediately, and then they get the mail. Then they can respond, put their. If you go to the next slide, please, and the next one, then they can respond and put their assessment on based on what, yeah, this is what it looks like. So you're going to analyze, like I've seen this lady, this is the scenario. Then learning plan, what did you learn from it? Additional actions, what else did you do to help the patient? All of that, you put it. And afterwards, the person is going to put their comments to see, oh, you've managed this patient very well. They're so happy about it. But then this one you have to discuss, then you'd request. It's always better to request ahead, like, oh, I would like to send you a ticket. Are you happy enough? And the person will say, oh, yes, please send me. Then you can send. Some people would not sign, some people would take forever. At times it would expire and then you need to send again. At times it would just be sitting there and then you have to resend again so that the person can respond. But it's advisable, like in a week, you should try to do like one CBDs and one KEX to populate your portfolio. So it's very good. So that's what CBDs is all about. You have seen the patients, you've made the diagnosis, then you've come to discuss. So that's CBDs. So the KEX, that is the person is there from the beginning, ideally, from you taking the history to examining the patients to arriving at your differentials to management of the patient. So the person is having a look. They would not say anything. They would just tell the patient in the room, like, oh, I'm just here to assess what Dr. Liadi is doing because I'll be giving feedback at the end of it all. And then afterwards, you would have requested, of course, before they come into the room, that I would be sending you a ticket for this. Are you happy to do a cakes for me? Then they'll say yes. And you would go through basically all these things: history, physical examination, clinical judgment, professionalism. And then the layout is similar to the CBDs, that you analyze what you have seen and then you send to them. Then at the end of the day, they'll put their comments in the assessor comment area and they will say what they feel. It's also like an avenue for improvement. They would put so that they felt you would have done it better like this, you could have requested for this. They put feedbacks there. So the feedback is not to say you haven't done well or to put you down. It's just to help you get better at whatever you're doing going forward. So that's what a KEX is about. Okay. So the educational supervisor, the trainings and not training, some trust would give you, whether you're like a trust grade, you're a training, your specialty doctor, whatever you have, some would give you educational supervisor and clinical supervisor. Other trust, it's only if you're a training that you have the luxury of getting the educational supervisor and clinical supervisor. So it depends on where you find yourself. But times, even if you don't have any of this and you have a pathway in mind and you're not in training, you can always walk up to whatever consultant you feel is your favorite and then request that, so I would like you to be my educational supervisor, or I would like you to be my clinical supervisor. They will either say a yes or a no. If they say no, you move on to the next one. And most times there's always like a college tutor in the department. So you can always walk up to the college tutor as well and say, oh, I would like. So if they're not able to do your educational supervisor or clinical supervisor, they can always tell you, oh, meet so person. They would have spoken to the person on your behalf and the person will be more than happy to be your educational supervisor or clinical supervisor. So the educational supervisor basically takes care of like your education, like your learning plan and your development. That's what they do. So there's like an educational agreement. They offer support and career advice. They conduct regular progress reviews. There's always like a meeting from time to time. The frequency of the meeting will be determined by yourself and your educational supervisor. And then they will see how you're doing. Sometimes you sit together and go through your portfolios and see what you've achieved so far. And then for the ones that you haven't achieved, they see how they can help you and place you in that situation that will help you to achieve it. So then they deliver a final summative assessment of the training performance. Then they act as mentors as well. Like if you need anything outside of education, sometimes they are very good to give advice and they're very good to guide. Oh, you're looking for a house, like you've just moved in into that department or that hospital, and then you're trying to get a house. They can signpost you to good places to get all of these things. So they help you settle well, basically. So people have had problems with their educational supervisor, and that could make the training very daunting for you. But then some have been very lucky, and their educational supervisors has been like their angels. But then if you having problems with your educational supervisor, because it goes a long way. If you have a very good relationship with the educational supervisor, then it's going to make your journey very smooth and all of that. If you have problems, you can always request to change, and then they will be willing to give you another person. It's just about your progress and your growth. So don't be afraid to speak up or anything. So the clinical supervisor takes care of the clinical parts of your training. So then they provide guidance, feedback, and support. They make sure they put you in that clinical placement. Let's say you're a training now and you're in ops and gynae. The clinical supervisor will make sure that like you're put on the section list so that you get your competencies for cesarean section signed off that way. They will ensure that you're put on the gynae list so that you get your competency side of. They put you in positions that would help you get your sign-offs. They make it very easy for you. That's the difference between if you're doing training and not training. In non-training, you have to chase things, you have to get the low hanging fruit. You have to push yourself basically. But then if you're a trainee, then your clinical supervisor is the one like pushing you, getting you everything that you need to make everything work out for you. So that at the end of your posting, you're able to meet your curriculum as per your specialty. You're able to achieve all that you're supposed to get and all of that. So most times the clinical supervisors and educational supervisors, they work together, like they collaborate with each other, and then they help you achieve your goals, and they make it very easy for you. Because training can be stressful, but then when you have these two angels with you, then it goes very, very smooth. Okay, that's the role of the clinical supervisor. So for the audit is like you review the clinical practice. There's a guideline. This is what you're doing in your trust, and then you compare the performance of the trust against what the guideline is. So most times there's always like an audit committee after you get a topic. Sometimes there's someone in the department that is in charge of the audits, like the audit lead, and then they have all the topics that are available to the trust. If you need to do an audit, you can walk up to them. Even if you don't have a topic in mind, they have list of topics, and then you can always pick one from it. And then after you've selected that, then you have to register it with the audit committee to be sure that, oh, someone else is not already working on this audit. And then after registration, then you go get your data. Then there's this set standard according to whatever you're doing. Like in ops and gynae, I would make reference to ops and gynae because that's what I do. Then you have the guideline, you have this is what the RCOG says about this. So that's your set standard. You collect data. After collecting data, you analyze, and then you come to a conclusion. The conclusion is supposed to be what will bring about the positive change, and then will be implemented. After you've come to the conclusion, it will be presented at some level. It could be presented like locally within your hospital, regionally, across many trusts, nationally, internationally. However you choose to present your audit, it could go that way. And then after the audit is completed and you've presented it and people are aware of this is what they should be doing, this is what they're not doing right, you give them a period of time, say 6 months, 3 months, then you can do a re-audit. And the re-audit will be about um if people have really learnt from what you presented, if things are now changing and all of those. So that's what audit is all about. So it could be anything. There's audits on, like I've done some. One is about antenatal corticosteroid that we're giving pregnant women going for cesarean sections and all. So the audit was not about like are people giving pregnant women these things. It's about, are they documenting that they've discussed the benefits and the risk of this corticosteroid with the pregnant women? Because some of them will just say, oh, they just told me to sign and they just ask if I'm happy enough. So that's like in that sort of way, you've kind of improved patient delivery, service delivery to the patients. Like people are now like explaining to them, this is what it's about. And then this is the benefit and this is the risk. And you're helping the ladies make informed decision of whether they want or not. And then so it's about documents. And so that was what the audit was about. And at the end of the day, we found out that like almost everyone in the department, not even one single person ever documented that they discussed. They would document that for the person is for steroids, but they wouldn't document that they had the discussion of the benefits and risk, and the ladies were happy enough to make their choice, you know. So it was a game changer. It was a very good one. So that's audit. You can always pick whatever topic you're comfortable with. It doesn't have to be like a very long one or lengthy one. Your size could be very small. It could be like 10, it could be like 50, it could be like 100, depending on like the target time you've given yourself to achieve it. Okay. And then quality improvement is like a continuous effort to enhance patient care and safety. So you plan something, you do it, you study, you hack, you cycle. So QIP is usually like much more smaller and faster to achieve than an audit. So it could be like you go and check what people are doing, like how they are prescribing medications, what is happening, is there errors, and then you come out with, oh, there's been errors, and these are the facts to like reduce this kind of errors and all of that. Sometimes it could be as much as people not writing allergies to medications, and then someone's going to give this thing. So QIPs are also there. They're very easy to do. The duration is shorter, and then you can also do that. All of this is just to improve service delivery, to make your work safe for everyone, both yourselves, your patients, and then to reduce the risk of litigation and all. And while you're doing all of this, you're helping your colleagues and you're also getting something in the back for it. You're getting your certificate for QIP, certificate for audit. And then if you're going for let's say you're going to go into the S3 pathways, there's like in the self-assessment score, there's like couple of marks for QIPs, audit, and all of that. And that like tends to differentiate those that would eventually get SC3 from those that will not, because we know SC3 is very, very competitive and all of that. So all these little things is they're very good. Like they push you ahead and they help you populate your portfolio as well. It's not very easy because the work itself is daunting enough. But then if you try to make time, it's something that is achievable, and then it's something that helps you. Okay, so I think that's what the topic is all about, basically. So I try to summarize it and all of that. So in conclusion, portfolio is essential for career growth and progression. It's invaluable in training. And then if you're getting your alternate competence for non-training roles, or if you're going through the CESAR pathway, whatever you're going through, it's very good to get portfolio and try to record things. And then that's the only way to tell people that, oh, I can actually do this. Yeah, people don't hear by mouth or by looking at it. They want to see what paper you have to back up whatever you're saying. And the ES and CS, they make the training stress-free. They provide the opportunities to get the sign off and make it very easy for people that are in training. Audit QIPs, improve clinical service, and ensure patient safety and satisfaction.